curfew, business fines, no, individual fines, mask not required for 2-year-olds, no, 8-year-olds, or teenagers playing sports. And why did you choose those ages? But the most alarming is Dr. Levine stating, in order for contact tracing to work, we would need 400 tracers. We only have a fraction of that. And in the same breath, she says, what a great job we're doing. Why is it that you can make decisions on such confusing numbers? When exactly were the people infected? Just like a hurricane where the EPG looks at the whole picture, I wish you would do the same here. Thank you.
Barry Jackson.
So why are caller comments never addressed? Only once has a caller's issues ever been addressed, which was last week, and it was regarding noise. Then you said they would be called back to discuss the issue. You will comment on non-COVID health issues, but you ignore every comment regarding COVID health issues. Since you won't comment on COVID health issues raised by the public, here's an idea. Let's set aside the same 20 minutes for public comments, but call it public discussions. Allow 5 callers instead of 10, allow 4 minutes instead of 2, and actually discuss the comments with us. I emailed everyone 2 weeks ago asking for someone to please tell me why public comments are never addressed. For 2 weeks, no one has responded. These are not personal attacks, just questions. Commissioner Overman, you are always the first to speak, but yet all you do is spend 20 minutes talking about contact tracing. After 4 months, we have 3.9 million cases in the U.S. The EPG has never cared about contact tracing with the 20 to 50 million cases of flu each year. That's about 1,000% more flu cases each year than COVID, but no contact tracing marathon conversations. 40 to 60,000 people die each year from the flu. No one talked about contact tracing or masks. Why? The flu season 24 months ago had 43 million cases and 61,200 deaths. Almost 50% more of those were in daycare and school-age kids. No one cared. Commissioner Overman, last week you commented on medical studies from universities supporting masks. Why do none of you ever comment on the private medical studies that talk about how masks are actually worse? Mayor Castor, 2 weeks ago, you made a comment about 0.01% death statistic. You said every life matters. I agree. But why don't you care about the lives of the flu victims every year? Just 24 months ago, flu season saw 61,200 deaths. Yet no social distancing, no mask mandate, no closures, no contact tracing, no hospital capacity concerns. Why? Because it wasn't an election year.
Tom Odom.
Yes, my name's Tom Odom, and I've heard members of this group say we want to be data-driven, and I think that's great. Problem comes from the fact that there's no scientific data on face coverings that people are wearing. N95 masks will block 95% of particles 0.3 microns or larger. The current coronavirus is 0.125 microns, or a third the size that the N95 mask will block. The CDC, the WHO, and Fauci have all said that healthy people don't need to wear masks. Did science change? I don't think so. There are no large-scale clinical trials proving that personal use of masks can prevent pandemic spread. But you've dictated that healthy people have to wear masks going into businesses, and businesses have to become the, quote, police, even though they're not trained in handling confrontation. And if that's not bad enough, the businesses could be fined $75,000 for a HIPAA violation if they ask unmasked people about their medical condition. I bring this up because of number 4 in paragraph 8 of the order. So you've created a lose-lose situation for businesses. If they let people in without masks, they could get fined. If they question people without a mask that come in about their medical condition, they could get fined a lot more. Or they could be easily robbed, like the Sam's Club in Brandon. And that's why Florida Statute 876.14 exists, and you basically tried to overrule it. Do you want to be data-driven about the mask? Here's the data. Ever since you've instituted the mask rule, the number of positive tests have skyrocketed, not gone down. Just look at the data. So I fail to see how you're data-driven on this decision. Unless you can show us large-scale scientific data that any type of face covering can prevent pandemic spread, you need to drop the mask order. Or if you think masks are a good idea, you should only recommend that people wear them, not make them against the law. So I urge you to vote against renewing the mask order. Like I said before, there are no large-scale clinical trials proving that personal use of masks can prevent pandemic spread. Thank you very much.
Okay, that closes the public comment section. Mr. Dudley, emergency management update.
Good afternoon. We continue to move forward with testing. Testing conducted last week, 8,600. Total tested to date, 67,799. I'd like to take this time to thank our USF teams that have been working our collection site at Lee Davis, South Shore, and Plant City. This week will be their last week at our collection sites. Our teams here will focus this week on transitioning them out to contract staff. So we certainly appreciate all their efforts. The next available appointment is 31 July. Logistics, we have 44 guests checked into our isolation site. And we would also like to thank the Children's Board Family Resource Center in Central Tampa for continuously providing art and educational materials for families in need at our Q&I facilities. Thank you for your support. And logistics issued 1,250 infrared thermometers provided by the state for local small businesses. And this concludes my update.
Thank you, Mr. Dudley, and I see no questions at all. Thank you very much.
Thank you, sir.
Public health update, Dr. Holt.
Yes, sir. This is Dr. Holt, Florida Department of Health. I'm going to first provide some updates that occurred over the weekend from the CDC, and then Mr. Wagner and I will review the EPI presentation. First, similar to what we came up on Thursday and discussed, was that the retesting of anyone after a positive nasal swab, this is the PCR, not the blood test or the antibody, you do not repeat that test within 3 months. If you do develop flu-like illness after 3 months, they advise checking for all of the other causes of influenza-like illnesses. And if that's negative, then consult an infectious disease expert. What this also impacted was the return to work guidelines that we talked about a little bit. They recommend symptom-based non-testing, essentially 10 days after your onset of symptoms, or if you were never sick, 10 days after you were tested, and in both cases you've not had any fever for that last 24 hours, then you are cleared. And a note again with some of the delays in testing, and as we've seen when we reach people, is that many times they have reached that close to, if not at the end of that period, and are, if they're well, they are cleared at that time. The CDC, based on preponderance of an abundance of evidence, as they termed it, now strongly recommends or even made a direct plea to wear masks. They highlighted a specific study that I found very helpful and encouraging. It was a hair salon in Springfield, Missouri. Two stylists were worked while they were ill, but they both, they and the workers both wore masks. There were 139 people that were customers that were felt to be exposed. No one became sick, and 100 of them agreed to be tested initially and then after an incubation period. So those two tests were both negative. So no one, despite exposure, there was no transmission at work. There were 4 household contacts associated with those 2 cases. With that, Mr. Wagner, let's go through the data.
Go ahead, sir.
We have added 439 cases since this was prepared for you last night. So we now have 24,135 cases. Again, this is an increase, but it is significantly less than what we had seen in the prior 2 weeks or even 4 weeks. The total percent of the total population that have been tested and positive by the nasal swab is showing a slight, steady increase. We're up to 1.7%. We've had 243 deaths reported. That means that of the total population that have died of COVID, that represents 0.017% of that population. As we look at the number of estimated recovered, or again, these are those that after 30 days have survived, that has increased since we last reported by 1,000. Anticipate that to continue to increase fairly significantly as we get past that early July period where we just saw such a large increase. Looking at the trajectory, our rolling 14-day average is 670. Small increase there, again, as noted. If you look a little at the 7-day average, there is a hint of slight decrease. The 14-day average of test, a little over 4,500, represents a nice increase of 16%. Rolling 14-day positivity rate, it's not been updated. I did my own calculation of a 7-day, which is 14.5%, showing again a steady decrease. I would note that again, as we talked about, we are still in community-based transmission, widespread and very active. The numbers per day, and if you want to compare other counties, you have to look at the number per day for 100,000 persons. And for us, we are comparable to Palm Beach. We need to continue to move closer to Pinellas. They have reported about 300 per day, which again on a rate is 30 per day. Both of these high, but definitely less than us. And what's notable is their positivity rate is now less than 10%. The extreme outlier that we must continue to work, and we need our public to continue to do the efforts and the acceptance of the practices that we've asked. Miami-Dade is reporting about 3,000 cases a day, or twice as many in a rate for 100,000, and their positivity rate is 20%. With that, let's go to the hospital data, please. Again, Dr. Chang, just I mentioned some of his disclaimers that due to the delay in the reporting of this data and the fact that not all the hospital report to him, these will always be less than the ACA, the data that the hospitals also report and are required to report to ACA. For Dr. Chang, the average number that are been in the hospital per day, last 7 days is 435. Again, I'd note ACA, that was number just on yesterday was 572, and that average was 556. University Village continues to be in a very important role to help us with this. They have a census of about 70. Bed occupancy on the Tampa General, the overall bed occupancy is 66%. Again, slight increase, but well below the 80% that we look for. The ICU is 83%. And both of these, particularly the ICU, is higher from the ACA data. Admissions, the Tampa General Reports data has 52 on an average per day, with a significant decrease from the previous 7 days. But again, this is inconsistent with the ACA reports, which are averaging 63. I would note the ACA does have 43 admitted yesterday, which is actually the first time we've been below 50 per that source in the past 2 weeks. Again, I would note that long-term care admissions are significant and steady over the last few weeks. I think, again, their vulnerability, with particularly in this time of transmission, remains. They've averaged about 12 admissions per day. Fortunately, ACA continues to open dedicated SNFs or partnerships with SNFs for COVID positive, and again, hoping to see one of those locally sometime near the future. We'll close with our deaths as of actual reported today are 243, and do represent an increase. Mr. Wagner, will you continue?
Thank you. Kevin Wagner, Business Analyst, Healthcare Services Department, Hillsborough County. As for the EPG members, you're viewing the updated dashboard that's publicly available. On the top left-hand side, again, this was yesterday's data, 23,706. We are now above 24,100 in total cases. Total fatalities, again, are 243. I like to mention on the second row, the 16.16% data was actually updated about an hour ago. So the 14-day positive average is slightly above 15%. I believe it was 15.04% when I just looked at it. Cases by gender on the third row, again, show the 52-47 split between females and males, and cases by age group are still, from an aggregate standpoint, in the 20 to 30 to 40-year-old range are their highest presenters. Trend of new cases per day, as indicated, the 7-day average is 649. The 14-day average is 668. So again, we are hoping to see that flattening, as we presented for Thursday, 3 or 4 days ago, a flattening of that information. And today's number was a little over 400. So hopefully that trend continues, but Sundays historically have always been lower on the testing results reports. So again, hopefully the trending continues to flatten. Testing information, this has been updated about an hour ago and will be reflected in the Thursday report. But again, there's been over 13% of the total populations equal to testing, most likely near 13.5% with the updated testing information. And there's always a lag in this information due to its updated weekly. Hospital patients presented as reported by the TGH data source. Again, the trend is going higher, as you see on the top row, the last 2 columns, a decrease. There is always a lag in the historical reporting data from TGH. But again, 435, as you see on the green line, again, that is probably where we are from a reporting standpoint on that data source. The hospital daily admissions on the bottom chart, again, shows 52 on the far right-hand side. When we look at going to prior to the week of July 12th, regardless, there is a slight trending downward in the presented admissions. And as Dr. Holt indicated from the ACA database, only 43 yesterday. So again, we hope that there is a flattening of the admissions as well and or decreasing. The inpatient utilization on the top right-hand side, the age group. On the admissions, hospitalization by age group, as we're seeing above 50 years of age, 50, 60, and 70 have the highest aggregate of the age group presented in the hospital. And the bottom chart, the illness by the emergency room visits. Again, as is updated, it was showing a slight decrease of 1115. We hope that the Thursday meeting will show the updated increase for the following week. As requested by an EPG member, we have updated or provided the emergency room complaint and admission for Hillsborough County. So again, individuals who are admitted to the hospital through the emergency room department, we don't have the raw data. We have the presented graph from the state of Florida report. But again, that shows a trending downward of nearly 40 to 50 in the last 5 working days. And I'll stop there. Thank you.
Thank you, Dr. Holt and Mr. Wagner. I see Ms. Snively recognized.
Thank you, Chair. I thank you, gentlemen, for your reports. Appreciate all the data that you work hard to present to us every week. I wanted to ask some questions, if I may, about the testing and some of the rates. We talk a lot actually about the number of cases and the positivity rate and so forth. And I think you mentioned, Dr. Holt, that Pinellas County is got a better per day rate than we do, and we need to be closer to 300. And please correct me if I misquote you, but we need to be closer to 300 per day and below a 10% positivity rate. So my first question is, how do we compare to Pinellas as far as the amount of testing that we're doing, or to other counties in general that are either similar in size? How much are they testing versus how much are we testing? It feels like we're testing, or it seems like we're testing a lot, which is good because we need to. But how do we compare?
Yes, ma'am. I don't have the numbers right in front of me. They have tested as a percentage of their population about 1% more than we have. Pinellas has. We're behind Orange County, Duval. I think I've mentioned this before because they have had state-supported testing way before we did. We've been at a disadvantage from that standpoint. Actually, I literally had the numbers in front of me, but I can't put my hands on it. But to put the exact percentage, they have tested about 1% more than our population. Pinellas has. I'll stop there.
Okay, maybe you can bring that number back to the meeting on Thursday if you don't have it right in front of you. But where are we on including the at-home tests from residents in Hillsborough County? We mentioned that previously, and I know there are a lot of individuals that are doing the at-home testing. So are the numbers that we're seeing are they still incorporating? Do they incorporate those in-home tests from LabCorp for residents of Hillsborough County? Or are we just looking at the county data that's reported to us from the testing that's happening at all of our locations?
Yes, ma'am. Again, we report every test, no matter what form it is, that is either a nasal swab that has a PCR, or they also include antigen testing now. But we have not seen much at all of the antigen testing. The home swabs that I'm familiar with that we are seeing are coming from the long-term care staffing that are now being tested every 2 weeks. I'm sure they're out there in the commercial. I haven't heard of any people directly or my colleagues that are using those for their patients either.
So they're not really being included in the numbers that we are seeing each week. Is that correct? The at-home tests?
No, I'm sorry, I wasn't sure. If they're tested, if they're used in this county, and I know the long-term care are, we get those results. That's an absolute, as long as the lab is following state law, national law, that those test results must be reported to the state of the resident. That's national. Those basically national law.
Is there a way to delineate the at-home tests from the tests that we're getting from the county information as far as that goes, so to see how many people are being tested at our sites versus how many are doing in-home testing or at-home testing?
If you're talking about LabCorp as the source, absolutely not. They
No.
just tell us a total number from LabCorp. If there was a lab and I could identify it that only did oral or at home, a particular lab that was dedicated to that, they do report the list by labs. There's about 1,500 that they report. Some of them, they range from 1, 2 labs that they report results from each lab, that lab, all the way to a million or so for LabCorps and the Quest. But there's no way for the big commercial Quest LabCorp to get it from the state reports. That would require something local, and I don't know how to do that.
Okay, and then thank you. And then my final question is, based on what you know about testing and based on your professional opinion, when we talk about the rate of positivity, would you say that the overall testing is a random or a non-random sample of the population? And how does that impact the rate of positivity?
It's a very good and somewhat intriguing question. It's not a random sample because the people have to ask for, they come. Random, we really kind of got just go around and just test a broad sample, particularly in the asymptomatic type of group. And much of our tests are coming from the private sector and not the public sector. They generally are symptomatic is based on the criteria of the doctors. So they have pre-selected themselves out as a person with an illness. So that would not be random.
So then how does that impact the rate of positivity? Would you say then the rate of positivity tends to be higher because the people who come to test either are symptomatic or have been around someone who has been positive for COVID?
Well, once you, particularly as your tests are going up, which we are, when you see your positivity still remaining high, that means there's a lot of active spreading infection in the community. And the only way to drive that down is for there to be more and more and more testing. Plus, what we really want to achieve is fewer and fewer infected people in the community.
Okay, well then maybe thank you for that answer. You know, I'm concerned about the rate of positivity, just like everyone else probably is concerned about that rate of positivity. But I do know that it probably is impacted by the fact that people who are tested are more likely to be positive because they have been exposed to COVID or they are having COVID symptoms. And so, but I agree with you, obviously, that the more testing that we do, the better we can get with lowering the rate of positivity. And maybe this group can focus on that and to see what else we can do as an EPG group to increase testing across the county. The more tests, the better. So I will leave it at that. Thank you again for your responses, and maybe that's something we can talk about in our discussion period on the agenda today. Thank you.
Dr. Houghton, Mr. Wagner, thank you very much. We appreciate it. Thank you. Ms. Beck, you're recognized.
Yes, thank you, Chair Miller, and good afternoon, EPG board members. Christine Beck, County Attorney. The only item on my update is the review of the face covering order, which is up on its 7th day, so would need to be considered for renewal at this time. And it's at your discretion, Mr. Chair, to entertain a motion to that effect.
So moved.
Motion by Commissioner Overman. Is there a second?
Second, Mayor Castor.
Second by Mayor Castor. Questions, Ms. Snively, you recognize.
Sorry, I meant to take my hand down, sorry.
Okay, seeing no questions, please call the roll.
Miller,
Yes.
Oberman,
Yes.
Merman,
Yes.
Cronister,
No.
Castor,
Yes.
Ross,
Yes.
Lott,
No.
Snively.
No.
Motion carried 5-3 with members Cronister, Lott, and Snively voting no.
Thank you. Now moving to EPG discussions. Floor is open for the discussion. Floor is open for the discussion. The floor is open for any, Ms. Snively, you recognize.
Just to go back to my previous comments regarding testing, is there anything that this group can do to create the more availability for testing? And I don't know if that's a question for Dr. Holt or Mr. Dudley or Mr. Wagner, but is that something that this group is able to do? Do we have the ability to do that? And do we have the desire to do that?
Who would answer that question, Mr. Dudley?
This is Mr. Dudley. I will tell you this group has done a great job as far as ensuring that the community has the resources that we need. You know, we're operating 9 sites plus mobile testing at this point. And we always have to keep in mind that all these resources that's required to get these sites up and running and to maintain them are tied together. Across the state and the nation, staffing is a problem. Having the qualified personnel to be out at each site, having the testing supplies, PPE, and the demand. So I would say right now we're running maximum that we can at these sites, and we continue to look for opportunities to keep these sites up and running. But staffing will be a challenge. Right now, our hospitals are finding qualified folks to be a challenge for them.
Mr. Dudley, since that question came up, and I think someone was comparing us to Pinellas County, how many sites would they have in Pinellas County?
I know that they just recently opened up the Mahaffey, and that's state supported. And they've been working with Baycare at the Trop. So not too sure how many more smaller community sites that they have up and running.
Okay. So we know of at least maybe 2. I think that's what I've heard in the past. 2, maybe 3 sites, and we have 9.
That's correct. That 9, that includes the Raymond James, but yes, 9.
Okay, just want to make sure.
Plus mobile testing.
Plus mobile testing. Okay. So we have 9 plus the mobile testing in Hillsborough County compared to Pinellas. So really, as far as I think I know, and maybe someone correct me, is 3, maybe 3. Commissioner Oldham, you reckon? Pardon me?
Commissioner Miller, this is Dr. Holt. I apologize. I did find the information that Ms. Snidely asked for.
Okay.
Pinellas has tested 50,000 less. They have done 140. We've done 190. My point is it's about the percentage of the population that have been tested, not how many have been done. My estimate is they've done about 14.5. We've done a little over 13% of our population. I'll stop there.
Okay. And I stand corrected. We have the 8 sites plus mobile testing.
Okay. All right. Commissioner Overman, you recognize.
Thank you very much. And I can appreciate the question regarding the number of tests and the testing, but to understand, it's still a little different when you go to a hospital or versus doing it at the county. At the county, you don't have to have symptoms. You can get a test. And while you still need to be symptomatic, to really have a test be important because, or at least close to symptomatic, to have the actual antibodies show up, so you don't end up with a false negative if you happen to be exposed. We have had an employer that actually decided to test about 75% of their employees using our mobile group, which has been terrific that they're available, especially in employees groups, where about 5.6% of the employees ended up testing positive. And of that, about 2% of those tested actually were asymptomatic, but still tested positive. So and that's just an employee group. As a way of sort of looking at it as an example of what we're seeing when we have a broad-based test available. With our hospitals, they typically are going to ask you to go use the county center or other ways to get tested. And we have an 11-day waiting period to get an appointment to get tested. So those that are symptomatic right now are going to be well along in the process to find out whether or not they were positive or not. Those that aren't or think they got it will probably be symptomatic by the time they actually get tested. So it's likely that, from what I understand of what I've heard from the docs and our professionals, it sounds as though we're getting more positives because by the time they get there, they really are having the antibodies that indicate they've been exposed. And I do think we're doing a great job on testing. Of course, more is handy as long as they're getting tested because they think they've been exposed or they're in a situation where they are around a lot of people a lot of times. So I thank Mr. Dudley for doing as much as he is and really appreciate the work that they're able to do to get a lot of people, tested. And I'll stop there.
Okay. Before I call on Commissioner Merman, let me say this. There's some very complicated questions asked of Dr. Holt and staff and others. If you can get those questions in advance to Dr. Holt or any other staff member that you would like to have that question answered during our EPG meeting, I would advise you do that. That way they will not be trying to find out information and scrambling to try to find out information on the EPG meeting while we're here meeting. If you can get that information to them, you know what your questions may be or your questions are, get that to them and then bring it forth in the meeting, and then they'll be able to answer that question much more accurately than they would if just shooting from the hip and they're trying to find out what that information is. Just wanted to say that. I think that's the best way to do that.
Commissioner Miller, I do have a question for Ms. Snively. She can bring it back to us, a report on Thursday of the number of open schools during the summer programs that actually were shut down or closed during the summer due to a COVID exposure. Thank you very much. If you have that data, I'd appreciate it.
Through the chair, yes, I can get that information for you by Thursday. I appreciate that.
Thank you.
Commissioner Merman, you recognize.
Thank you, Mr. Chair. And again, I want to echo the same thoughts that you and Commissioner Merman shared. I think our staff at the Emergency Operations Center has gone above and beyond on the testing. And I really, if I could go to every site and thank them personally, I would, but I think that's a little dangerous. But I hope that all these, I hope that every person working these testing sites knows how much they're appreciated. And it comes not just from me, but I think from everybody that's on this emergency policy group. To have 9 sites up, well, one of them's mobile, I mean, it's an incredible feat, and only one of them state run. That is, all these other places like Miami, Broward, they have a lot of state-run sites available. So I just wanted to make that point because this has gone on way longer than any of us ever anticipated. And these guys are working, you know how hot it is outside. Just imagine being out there every single day with these testing sites. And then we have contracts up, and I was going to ask that Gene Early come back to us on Thursday. There are many contracts that will expire at some of these testing sites, and that will be a major concern for us going forward how can we keep these contracts going so we can keep the people getting tested as much as we can. I guess my only question too would be, and it's not a question to Ms. Snively, but when she asked those questions, I was trying to figure out what the purpose of the question was, like where was it headed? I guess maybe that was something I just couldn't figure out why we needed that information or where was it headed towards. That's, so if you're coming back Thursday, if you could just state that. And then third, I have been talking with Jean early and working in advance of the schools opening to prepare a kind of a task force, much like we did with the hospital group, and come back Thursday and report to us what that would look like to just prepare for any kind of surge that would happen in children coming down with COVID. I am completely concerned and for our children going back. I have 2 grandchildren that will be, they aren't in the public school system right now, but they will be heading back to their pre-K programs. And it is a huge concern for our children. And I think we can work ahead of it, just like we could have done with the hospital group that Mr. Merrill put together. So I have talked with Jean and Dr. Curran about this, and they will, I've asked them to come back Thursday and we can put this on the agenda to report back on any kind of children's surge from going back to school. Thank you all very much.
Ms. Snively, you recognize.
Thank you, Chair, and thank you for posing that question, Commissioner Merman. And I don't have to wait till Thursday. I can actually answer that question for you now. But the point of my question was, you know, again, since we focus so much on cases and rate of positivity, I wanted to be clear that the people who are getting tested have a higher propensity of being positive because they more likely have been exposed to COVID or have had symptoms of COVID. And so we focus on a high positivity rate, but these folks that are testing have a higher propensity of having COVID because they're not a random sampling. They're a non-random sampling, if you will, a focus sampling. So that was the point of that question, and I appreciate the opportunity to answer that. And with all due respect, Chair, I understand what you mean about asking questions to Dr. Holt. And I certainly would never expect him to have every single answer to a question that I asked. But the reason that I do pose these questions publicly is because I like the public to hear the questions that I'm asking. And so I would never intend to put him on the spot to be in an uncomfortable way. I always would pose the question and expect it to hopefully be answered by the next EPG meeting. And so if I wasn't clear about that, I certainly want to make myself clear that I don't necessarily intend to put him on the spot as much as I want to ask that question publicly so that people can hear the questions that I'm asking on this meeting, during this meeting, not necessarily via email questions. So I appreciate that. And then with regard to the schools, we do have a meeting on Thursday afternoon, which is immediately following the Thursday EPG meeting. So that information that Commissioner Merman asked will be very helpful for this group and for the school board in making a determination whether or not students will be going back to school traditionally or e-learning or virtually. So right now, parents have been given 3 options. The deadline to declare intent for parents was last night at midnight. So we're waiting for the data to come back to see what parents' choices are. However, the school district will vote, the board will vote on the reopening strategy on Thursday afternoon after this EPG meeting. So thank you, and we'll look forward to, I'll share hopefully more information with you on Thursday if that is acceptable. Thank you so much.
Ms. Snively, let me clarify what I said. It was not an intent of not not allowing you to ask a question in front of the public so the public hear your question. My concern was, and the question was, if you could submit the question to Mr. Dr. Holder, Mr. Wagner, or any other staff member, so they can get a clear, concise, detailed answer. You can still ask your question, and then at that meeting, ask your question, and they can give you a much more detailed answer to the question. That's basically what I was saying. I'm not saying don't ask the question. Just give it to them in time, so when you come forth to the meeting and ask your question, they will have a detailed, concise answer for you.
Thank you. I appreciate that that advice. And sometimes I can get that done ahead of time. Sometimes I think of a question during the meeting. So, but I'll try and give them additional time before to have the time to answer that question when I pose it at a meeting. But thank you so much. Understood.
Is there any other discussion items to discuss today? Any other items to discuss? Seeing none, we'll meet again on this coming Thursday at 1:30, and therefore we stand adjourned. Have a great day.